So as we learned before, today we found that the TT-TTG distance, I agree that greater than 20 millimeters is abnormal, 15 to 20 is borderline, and less than 15 is normal. My cutoffs are a little bit different. My magic number is if a patient is having a procedure, I use a TT to TG of about 15 to 16. And any patella alta, I will plan on doing a tibial tubercle osteotomy. This was a really nice paper that came out, and I call your attention to the lower part down here. This was done last year with Seth Sherman. And their technique is to divide out the location of the lesion. So this is for the distal lateral patellar lesions and the TT to TG greater than 15 millimeters. An isolated tibial tubercle osteotomy without cartilage restoration has good outcomes at almost 4 years. For these pan or central lesions with a TT to TG that's elevated, you need to do a steeper osteotomy, and the overall survival rate is about 75%. So this is the first example. This is a distal lateral lesion. And this is a 25-year-old patient with distal and lateral chondrosis, painful effusions, mechanical symptoms, and believe it or not, with these x-rays, no actual instability. We did a tibial tubercle osteotomy, first on one side, then on the other, separated about 6 months apart, and overall, the patient did really well just with that procedure. This is the other most common option where you have kind of a central defect in the patella, either central or central and lateral, and usually there's starting to be some cartilage degeneration in the trochlea. And this was the patient that I showed earlier, and we ended up doing a tibial tubercle osteotomy and Macy procedure. I think a tibial tubercle osteotomy improves the outcome of cartilage repair. So almost always, if I'm doing a cartilage repair, I'm going to be doing an osteotomy, especially for patellar lesions, trochlear lesions a little bit less. This is a long-term study looking at ACI, so the original Macy, and they found that with a tibial tubercle osteotomy, 70 to 80% of patients had good to excellent outcomes even at 15 years. With ACI alone, the numbers drop off, and especially important is this early failure rate. So the patients are failing pretty early on for up to over about 25%. So these patients aren't going to be nearly as happy. So I think it's definitely worth adding a TTO whenever you're thinking about it. Overall, osteotomy and cartilage restoration should usually be considered together. This was a nice study by Seth Sherman, again, out of Stanford. They looked at over 1,000 patients, and they found that doing a concomitant osteotomy at the time of an ACI or osteochondral allograft procedure reduces the risk of reoperation with a similar rate of complications and overall similar costs. So overall, it's probably the dominant treatment strategy when you're doing a cartilage procedure. This was another study that came out recently. This is a meta-analysis of 59 articles, and they concluded that patellofemoral cartilage restoration leads to improved clinical outcomes, low rates of complications. There's no overall statistical difference among techniques, but the failures were higher with the osteochondral allograft. That's probably also because those are the ones that you're doing for more complicated cases with bone loss. So what do I tell my patients who are undergoing a tibial tubercle osteotomy and cartilage procedure? I tell them that at 2 years, 85% of them are going to be happy. At 10 years, 75% of them are going to be happy and won't have needed a second surgery. I tell them that they're probably going to be able to go back to sports, a greater than 8 in 10 chance, but it's going to take 8 to 10 months for them to go back. So in summary from both these talks, I think for the biologic treatments for patellofemoral pain, PRP is safe and effective for pain relief, although in all honesty, I don't use it very often. It does not regenerate cartilage, and there's no evidence at this point for stem cell therapies. For cartilage strategies for patellofemoral pain, I think Macy is the preferred option. I recommend adding in a tibial tubercle osteotomy for patients with a TT to TG greater than 16, and any patella alta should be corrected at that time. You can tell your patients to expect good to excellent results, but wait 8 months before they actually feel like they're happy. Thank you.